Hi, Jen. You ready to moderate this one?
Yes, hi Michael, how are you?
Good.
Good to
Thank you.
see you.
Yeah, thank you for doing it.
Sure, no problem. Jesse, I'm going to go ahead and get started then. Welcome everybody. This is oral abstract session A. It's Monday afternoon and at 2:30 we have 4 speakers during this session. Our first speaker is actually not able to join live, so we have a pre-recorded talk that we'll be playing for you to get us started. And that speaker is Danielle Muscat. And so she's going to be talking about equity in choosing wisely, the impact of health literacy on consumer healthcare decision-making, and methods to support conversations about overuse. So we will just go ahead and get started right away with that. And Jesse is going to start that presentation for us. Thank you so much.
Thank you for the opportunity to be here today to speak to you about our work with the Choosing Wisely questions and evaluating their impact for people with different levels of health literacy. My name is Dr. Danielle Muscat. I'm from the Sydney Health Literacy Lab in Australia, and I'm probably asleep right now, so apologies that I couldn't join you. Before I begin, I'd like to acknowledge the research team involved in this project and the funding from the National Health and Medical Research Council in Australia, and just provide an overview of the conflicts of interest for this research study. So for some very quick background, unnecessary and potentially harmful services account for a significant proportion of total health expenditure, and the need to eliminate unnecessary medical care, decrease waste, and reduce overdiagnosis has received increasing attention from health systems over the past decade. And one initiative that has gained momentum worldwide is Choosing Wisely. And this campaign seeks to encourage clinicians and patients to talk about medical tests and procedures that may be unnecessary and in some instances can cause harm, which outweighs the benefits. And leaders of the campaign consider communication between clinicians and patients during routine clinical encounters as a key mechanism for change. And although many of the resources and campaigns for Choosing Wisely are targeted at healthcare providers, there have been 5 questions that have been developed for patients to ask their healthcare providers to facilitate better conversations about overuse and overdiagnosis. These questions are shown on the screen, and they include: do I really need this test, treatment, or procedure? What are the risks? Are there simpler, safer options? What happens if I don't do anything, and what are the costs? However, in the shared decision-making space, a number of researchers have argued that a form of intervention such as this must be preceded by a preparation phase where patients are supported and prepared to engage in shared decision-making and ask questions such as the Choosing Wisely questions. And this would be by, for example, informing patients about what shared decision-making is, explaining that they're 2 experts in the clinical encounter and describing the complementary knowledge that patients bring, challenging attitudes that there are right or wrong healthcare decisions, and redefining perceptions of a good patient and promoting social acceptability of question asking and shared decision making, and building patients' belief in their ability to take part. It's only once that preparation has been done that they suggest you should provide patients with forms of enablement such as the Choosing Wisely questions. However, despite a wide international promotion of the Choosing Wisely questions, evidence of their impact for people with different levels of health literacy hasn't been evaluated quantitatively. And studies are also yet to evaluate this preparation versus enablement model for people with different levels of health literacy also. And so it's probably unsurprising then that the aim of this study was to examine whether the impact of the Choosing Wisely questions and or an additional video preparation is modified by health literacy. And we also wanted to do some exploratory analyses looking at the relationship between health literacy and patient outcomes related to question asking and shared decision making in this context of low value care. So to answer these research questions and to address these aims, we recruited adults living in Australia from a social research database, and we used educational quota sampling to recruit participants with lower health literacy, which was assessed using the newest vital sign. The QR code on the screen links to the protocol for our methods for this study, if you'd like a little bit more detail. So we used a randomized design where we collected demographic characteristics, assessed and stratified based on health literacy. Then we provided all participants with a low-value care scenario, and then we randomized them to either receive the preparation video alone, choosing wisely questions alone, or both interventions, so preparation followed by enablement. And this is just a schematic of that, and we also included a control arm. And so just as a sneak peek for the preparation video, this is kind of part of what it looked like.
Asking your doctor questions is one way to make this happen and can help you to make decisions that you are happy with.
There are benefits and harms, or pros and cons, to every treatment. Asking questions and sharing decisions with your doctor can be helpful to understand the options offered to you and their benefits and harms. For some,
So we measured outcomes both pre and post intervention, our primary outcomes being self-efficacy to ask questions of the doctor and to be involved in decisions, and intention to engage in shared decision-making on a 0 to 6 scale. Our secondary outcomes, including intention to follow low-value treatment plans without further questions, knowledge of rights related to shared decision-making, attitudes towards shared decision-making and preparedness. And we also looked at the questions that patients would ask the healthcare provider given the low-value care scenario that they were provided. We analysed data as intention to treat with linear and logistic regressions. So for our results, so we had 1,439 participants included in our final analysis, and just under half of these had limited health literacy as assessed using the newest vital sign. 48.8% identified as female, and just over a quarter were aged between 31 to 45 years. Okay, so to assess whether the impact of the choosing wisely questions or that preparation video are modified by health literacy. So our primary analysis identified that the choosing wisely questions and the shared decision-making preparation video improved intentions to engage in shared decision-making and supported patients in identifying questions which aligned with the Choosing Wisely campaign. However, neither intervention changed participants' self-efficacy to ask questions or be involved in decision-making, intention to engage in shared decision-making and shared decision-making knowledge. So when we did our stratified analysis, looking at the impact of health literacy, there was actually no statistical evidence that the effects of the Choosing Wisely questions or that preparation video were modified by health literacy for most primary or secondary outcomes. For participants who received both, either the video or both interventions, so the video plus the Choosing Wisely questions, those with limited health literacy were more likely to indicate that they would use interventions again compared to individuals with adequate health literacy. For our exploratory analysis, just looking at the relationship between health literacy and patient outcomes, we found that compared to individuals with adequate health literacy, so this is averaged across trial arms, those with limited health literacy were less likely to have complete knowledge of patients' rights in relation to shared decision-making. They were less likely to have positive attitudes towards shared decision-making, and they were less likely to identify questions to ask a doctor which aligned with Choosing Wisely campaign. So questions about options and benefits and harms, for example. Individuals with adequate health literacy, compared to those, with adequate health literacy, those with limited health literacy were more likely to indicate that they would follow low-value treatment plans without further questions. There were no statistical evidence of a main effect of health literacy, however, for either primary outcome, so self-efficacy to ask questions and be involved in shared decision-making and intention to engage in shared decision-making. So what does this all mean and where to next? So in the context of low-value care, lower health literacy in this study was found to be associated with an increased preference to follow low-value treatment plans without further questioning, less positive attitudes towards shared decision-making, lower knowledge of patient shared decision-making rights, and it was also associated with being less likely to ask questions which align with Choosing Wisely topics on campaign. Our findings suggest that the impact of the Choosing Wisely questions and a video intervention to prepare patients to engage in shared decision-making did not differ based on an individual's health literacy. And so further work is still needed to develop targeted and tailored interventions to ensure that individuals with lower health literacy are enabled to be involved in healthcare decisions related to low value care. So apologies, I couldn't be there to answer questions live, but please do email me if you have any interest in knowing more or want to chat more. And the QR codes also link again to our published protocol and the primary results of this study. So I hope you find that useful. Thank you very much.
Okay, excellent. Well, that was a great presentation, and Danielle had her contact information. I think you can also access it on the website. So if you have questions about that talk, feel free to reach out to her, and I'm sure she would be happy to talk with you. So up next, we have our first of our next 3 live speakers. And so speaking next will be Joseph Dexter and Vishala Mishra, and they will be talking about linguistic fairness and health equity in the U.S., the case of multilingual public health information about COVID-19. So I'm very excited for this one, and we'll look forward to hearing what you both have to say.
Sorry, I had to unmute myself first and then
That's okay.
share screen. Let's try this again. Can you all
Yep,
see my
great.
screen?
Yes, excellent.
Thank you so much. So good afternoon, everyone. I'm Vishala Mishra, and I'm going to give a brief overview of this collaborative project about language equity and public health. As we are all very familiar with, language and written communication is at the heart of conveying medical and public health knowledge to the public. This has been especially true over the past 3 years, where the pandemic has required rapid dissemination of critical guidance and coordinated efforts to counter misinformation. As has been discussed in some of the earlier sessions today, and we've known for a very long time, going back to the IOM 2004 report and NUTBEAM's 2008 framework, that health literacy is a critical mediator of healthcare access and outcomes in the US. Health literacy is a particular concern for the 67 million people who speak a language other than English at home, or who otherwise have lower English proficiency, which is about 25 million people. Accordingly, there's a particular need for public health guidance about COVID-19 to be equitable in its language coverage and employ accessible communication strategies, something that we and many other groups have found to be lacking, even in Anglophone materials. Now, given the scope and urgency of guidance provided, official COVID-19 information served as an excellent context for studying linguistic fairness in US healthcare. With that in mind, we evaluated 2 important factors across a range of federal and state resources. The first factor we considered was information availability. That is, are there any resources at all written in the languages used by the intended audience? Now, the second factor was information accessibility. So for the information that is available, is it likely to be understood and trusted by the audience? So on to the first question. State health departments, of course, put out lots of official health information about COVID on their websites, starting in the earliest days of the pandemic. That made it possible to examine the demographic fairness of public health information in the US as a case study. So in other words, to address the fundamental question of whether most speakers of a language other than English had access to state-specific guidance in their primary language. So to do so, we conducted a systematic review of language coverage over all 50 states, and that revealed a lot of heterogeneity. As you can see on the map, some state websites were exclusively Anglophone, and others had COVID-19 information in dozens of languages. We then compared that data from the Census Bureau's American Community Survey, and we were able to estimate how many people had access to 0 information in their primary language. Now, the bottom line number is quite concerning. From our analysis, we find that about 4 million people, or about half of everyone in the US who does not speak English or Spanish, had no state-specific information available. Over to you, Joseph.
Yes, thanks, Vishala. So I'm Joseph Dexter, and for the second half of the talk, I'm going to discuss our work specifically with Spanish language COVID-19 guidance. So the demographic analysis on the previous slide addresses the question of information availability, but of course it tells us nothing about the quality of the multilingual materials themselves. Now, unfortunately, we did not have the resources and linguistic expertise to do a rigorous evaluation of accessibility across dozens of different languages, but instead, we took a closer look at Spanish on the assumption that, given the size of the user base, it would provide an effective upper bound on communication quality. So as you can see, we started with a readability analysis using 5 Spanish formulas, which revealed that the vast majority of FDA, CDC, and state health department pages were written at well above an 8th grade reading level, and were often similar in text complexity to our most difficult benchmark corpora. Now, those corpora I was just talking about are from March 2021, and it's reasonable to ask whether the readability of federal COVID-19 guidance improved at all over the course of the pandemic. So to address that question, we collected updated CDC and FDA documents from January 2022, when the surge in cases driven by the Omicron variant required rapid dissemination of substantial new information. And as you can see on the slide, differences in median readability were minimal, not exceeding 1 grade level for any of the 5 metrics, suggesting that poor readability has remained an ongoing issue. Now, as many of you know quite well, standard readability formulas consider only a narrow range of linguistic features and have well-known limitations for health literacy research. So to generate more comprehensive data, we applied the CDC's Clear Communication Index, or CCI, to their own Spanish language web pages. Developed in 2014, the CCI is a state-of-the-art 20-point assessment covering messaging, use of visualizations, risk communication, and other important items. For this analysis, we translated the CCI questionnaire and instructions from English to Spanish and trained 3 student research assistants, all of whom are native Spanish speakers and were blinded to the objectives of the study, to apply CCI to the COVID-19 documents. So strikingly, we found, out of the 115 CDC documents reviewed, every single one received a consensus CCI score below 90%, which is the CDC's own standard for a passing grade. Any lower, and the material should be revised to improve clarity. And from a statistical model of the CCI scores, we found the most common weaknesses across the corpus were limited use of visualizations, as well as failure to describe the probabilistic nature of risk and the scientific evidence underlying specific recommendations. So overall, we would argue that the Spanish readability and CCI results highlight a large gap in communication quality, even for relatively high-resource languages. So before wrapping up, Vishala and I would like to acknowledge a number of individuals and organizations, including especially our 2 co-authors who couldn't make it today, Damian Blasi and Adolfo Garcia, and as I said before, the student research assistants who played a critical role in the CCI analysis. And finally, for anyone interested, on the next slide, we have a link to the full preprint of the study. Thanks very much.
Great, thank you so much. I think what we'll do after each talk is take a question or two, and then we can have more discussion at the end as time allows. So does anyone have a question about the last presentation? And you can, I'm not sure if you can unmute yourselves, but you can put a question in the chat and then I can read it out loud. I had a question. I really like that clear communication index. I use it a lot in my classes and trainings. And I was curious because it sounded like you found that one of the reasons that the scores were lower, if I understood correctly, was there was a lack of visualizations in a lot of the documents. And I was curious if you saw any good examples of visualizations when you were assessing the documents that, you could point to if people wanted to be able to improve their use of visualizations in their own materials.
I can take that question in a somewhat limited way and say that while we did not, this is important work in terms of there are other groups that did a better job compared to us of collecting those visualizations that actually from federal sources, which actually worked better. But I think in my very limited knowledge of this, I would say that official information did not do a very good job of using visualizations overall.
Okay, thanks. And along a similar line with the communication index, there's a question in the chat about whether or not you analyze the English version of materials, because I think what you presented was analysis of the Spanish version.
Yeah. So all the data that we showed was for Spanish CDC pages. We did not do anything similarly comprehensive for English, just because there's a lot of manual work required for deploying CCI at that scale. We've, as we alluded to briefly, we've been quite interested in parallel questions with English, and the results that we've gotten for readability, syntactic complexity, use of jargon, things that can be more easily automated, all suggest that, right, there would likely be similar issues with an English corpus. So I don't want to suggest that it's a case of, right, everything is perfect with English and then deteriorates rapidly when you move to Spanish, but rather that even at the highest end of the spectrum in terms of high resource languages, you continue to have right, non-compliance with communication recommendations.
Yeah, and I'll just ask one more quick question before we move on. Do you have any thoughts for people who want to apply the Clear Communication Index in their own research? It is time intensive. Did you find any tricks about when you were using it that you think would be helpful?
So it was extremely important to be methodical in training the people who worked with it and really thinking through some of the questions involved in adaptation from English to another language. So even though we had a lot of tools at our disposal, right? So our other two co-authors are native Spanish speakers, and we were working with student RAs who were also native speakers. It took a lot of effort to think through how best to adapt each question, and then also, right, just some time, right, to get a sense of how the various dimensions would apply to this particular corpus. So I think that's the main thing I would say, is try to invest in some of that work and that training at the outset, and then hopefully that will yield downstream time savings as well as higher quality data. Did you want to add anything, Vishala?
No, I think you covered the bases. It was we definitely had access to literacy experts, and and there's a lot of training material on CCI that we did utilize, but we definitely found that when translating to a different language, it did bring up a whole new set of challenges that it's important to be mindful of.
Great, thank you. And if anyone thinks of any other questions, feel free to put them in the chat and so that you don't forget them by the end of the session and we can get back to that. Okay, so we'll move on to our next speaker. And our next speaker is Steve Colliger, and Steve will be talking about an examination of health literacy in the Asia Pacific region, a report from the Lymphoma Coalition. Okay, thanks, Steve.
Thank you for having me. Let's see here. Can everyone see my screen okay?
Yes, thank you, Steve.
Okay, great, thanks. Thank you to the organizing committee for allowing me to have the opportunity to present the findings from our examination of health literacy in the Asia Pacific region from the Lymphoma Coalition. So to jump right in, the report on health literacy was derived in part from three aspects of activities with our group. The first aspect is the 2022 Global Patient Survey. We also conducted some community advisory boards, which consist of qualitative focus groups, and this was all on a virtual setting. And it spanned various time zones. We also examined policy from the aspects of, is there a national standard, and what that standard focused on, how it was funded, and how the outcomes were measured. But for this talk, I'm going to just focus on findings derived from the Global Patient Survey. So some key demographics with regard to the Asia Pacific region. We collected responses from a variety of countries here, including the four principal respondents were Australia, China, and India. We got 3,206 responses, 2,218 from patients and 988 from caregivers. And I've mentioned those percentages previously. Females represented 57% of the patient population, that's excluding caregivers. And the mean age for the patient was 48 with a standard deviation of 16. Most patients reported completing post-secondary education, with 60% having completed college or university and 11% postgraduate. So some of the findings that we found here is that most patients preferred to receive information from their doctor, which is unsurprising. I think that's the point of contact for most patients when they're diagnosed with lymphoma. They are seeking expertise from their doctor. And surprisingly, most patients, 63% of them, wanted their doctors to tell the full truth about their diagnosis, even though it may be an uncomfortable or unpleasant topic. However, few patients and caregivers felt very well informed about the process and stages of their or the patient's healthcare, which was quite striking. And once again, I think this is pretty common with constrained resources, is that a minority of patients indicated that they had sufficient time to think about the treatment options before a decision was made. And I think what's interesting is this is an important aspect, because we are getting into the realm of multiple treatment options for lymphoma now. There's more, and with that, the amount of information that's required to be absorbed, assimilated, if you will, it represents a greater burden for time. The majority of patients, 40%, would like the doctor and patient to be jointly involved in the final decision on healthcare, with an additional 30% wanting their caregiver involved as well. So a full 77, a full 3/4 of patients want to be involved in the shared decision making, want some sort of shared decision making as well, which is also quite striking when we go back up to the third point here, is that there's an incongruence between what patients have in terms of comprehension and what they want. And only half of patients felt involved in the decisions surrounding their care and treatment. So this has some implications, which include patient comprehension is well below what patients and caregivers would prefer. I think there is a potential, probably more than a potential, there probably is a power imbalance between patients and their treating physicians. And I think it promotes an environment that's conducive to the abdication of power to the treating physician, because they're the ones with the information. And as I mentioned previously, there is a clear incongruence with patient preference. And increased effort must be made to enhance health literacy to address the power imbalance between doctors and levels. And this is really a systemic problem that requires a policy funding, and most importantly, it requires a paradigm shift where physicians have to acknowledge that the patients have a right to this information in order to actually make their own decisions and involve the doctor with their at their discretion. So as several of the speakers have talked about, health literacy, I feel, is the gateway to shared decision making. But there are barriers, and there's a barrier of language. Terminology is a huge one. There's a steep learning curve compounded with the traumatic experience of receiving a cancer diagnosis. So much information is required to assimilate. And as the previous speakers have talked, there's the delivery method that includes, that we can talk about. There's different verbal ways, pictorial ways, and written ways, and all of these methods must be integrated together to actually reach the widest audience possible. There's also barriers to communication, and there's an unwillingness, what I call an unwillingness to transmit. People need to speak up. Patients need to speak up. They need to make their feelings known, their preferences known. And I think it also goes both ways, that doctors need to actually communicate, and they need to find a way to communicate in a way that simplifies the terminology to reach as many people as possible. But there's also an unwillingness to receive. Patients may not want to know everything, and by that way they have reduced information. And I think it also applies to doctors as well. They have they don't want to hear that they're more disease focused and not so much about being patient focused. And then there's, I think, the real goal here is establishing what we call level setting, where there's a mutual understanding of the disease, treatment, and prognosis. And however, that level setting has to be sensitive to ethnographic heterogeneity, which in the Asia Pacific region, we have countries like Australia, and then we have smaller countries like Vanuatu, and what may be appropriate for Australia may not be appropriate for smaller, lower income countries. And so we have to be sensitive to that. And some of our work with the Lymphoma Coalition is to identify countries with certain sets of values and foster collaboration between those countries to derive more specific policies and get countries borrowing ideas from others that have similar values. And at that, I will end with this slide, and I'll be happy to take any questions that you may have.
Great, thanks so much, Steve. Does anyone have any questions for Steve?
Hi, Steve. This is Janelle. I just wanted to say this also makes me think of the implications for clinical trials.
Mhm.
and other health research, because then you not only have all the regular health stuff, but you also have the research and participation and the ethics surrounding that to communicate. And I'm curious about the degree to which anything came up about clinical trials or investigating, options that aren't approved already.
Yes, we did have some clinical trial questions in the report. However, it's important to note that due to the heterogeneity of the region, that it's not like looking at Europe where clinical trials are largely accessible, but due to the heterogeneity of the region, we don't think that clinical trials are that available in some of the smaller countries. We're just having trouble getting what we consider the standard of care available in a lot of these countries. And so the short answer to your question is I don't have the data at the tip of my finger to tell you what the clinical trial access was and how it was in developed in high income versus low income countries. I don't have that at the tip of my fingers, sorry.
No, that makes a lot of sense. And as you say, you have to, it's the standard of care first, right?
Yeah.
Before we can go to that next level.
Yeah.
Super interesting talk.
Thank you. Was there anyone else? Okay, if anyone in the abstract that was submitted, there is a URL to the report for anyone who would like to read it.
Oh, great. Thank you so much, Steve. Okay, great. And now we have our final speaker, Janelle Shu, and Janelle's going to be talking to us about conceptualizing health literacy, a framework to build organizational health literacy skills. Thanks, Janelle. Great, and I can see your slides now. Thank you.
Yeah, getting all the buttons pushed.
Yeah.
In a good way. Thank you all for being here today. My name is Janelle Shu, and I work at Communicate Health, and I am here to talk about work that my team and I have been working on with the National Network of the Library of Medicine in the United States. So tell you a little bit about us. There's me. Communicate Health, we're really focused on how can we design health information and products that are easy to access, understand, and use so that we can improve people's health and their lives accordingly. And obviously, equity is a huge part of this. The network of the National Library of Medicine, their mission really focuses on progressing medicine and improving public health. And they have a dual focus here. One is on working with U.S. health professionals so they can get access to the information they need, and also working to really improve access to information at the individual level. So that people can use that information to help make informed decisions about their health. And for both the mission at CH and at NNLM, obviously a big part of that has to do with what can we do to make sure that we are providing this information in a way that people can access, understand, and use, which, seems like it should be pretty straightforward, but as we all know, is very tricky. So we've been working with NNLM for a couple of years now on a variety of projects. And in 2022, we started to work with them as they're really trying to get everything within their organization aligned with health literacy best practices. And they wanted to start by finding or developing a conceptual health literacy framework to guide their work. And so we started off to do just that, to identify or develop such a framework. So our research questions really centered around, what are the key factors, especially for individual health literacy? What are the main components of individual health literacy, the main components of organizational health literacy? And then obviously a tricky component here is what are the relationships between these factors and their main components? And then once we kind of have that information, how do we visually conceptualize that? So some really interesting, complex, and challenging work that we've been doing in our first year. That's what I'm going to focus on today. We started off with a literature scan, really looking at different health literacy frameworks, different health literacy resources, and we were looking for a framework that really worked for an NLM, and found that none of the existing ones were as comprehensive as what we were looking for. We were really focusing on what the common components are. And in our research, especially around individual literacy, health literacy, and organizational health literacy, there didn't seem to be frameworks that were comprehensive in conceptualizing those. And we also conducted subject matter interviews with a focus on these same pieces. So as you can imagine, we had a number of findings came out of this. And I'm going to spend most of the time today going through the figure that we developed, our draft figure for this framework. But before I introduce that, we ended up synthesizing the findings, and we really found that there were 3 different levels, if you will. There was the individual, the consumer individual, and the information that they're trying to access, understand, and use. Another level was professionals and organizations who develop and share out that information. And then kind of impacting everything are the social and cultural determinants of health. And then we talked about the relationship between these different factors. So we have a couple different arrows that try to convey how these components, these levels work together. So let me go ahead and zoom in here so you all can see this a little bit better. But this framework here shows, let me zoom in. All right. There. Can you all see that?
Yes, thanks.
Great, thank you. So as I kind of gave you a preview, we ended up seeing in our analysis 3 different levels. And historically, there's been a lot of focus on the individuals, and almost a deficit framing of that, of do individuals have or not have the necessary ability to access? Can or can't they understand? Can or can't they apply information that they're accessing? And, over the last 20 years, especially, and more so in the last 10 years, there's been an increased recognition that we talked about earlier in this session here today of professionals, the individuals that work at different organizations that and what skills do or don't they have to make information easy to access, easy to understand, easy to apply. So that's the second level. And we were inspired by the socio-ecological model of really how do we recognize the fact that even organizations have to work within the system of our society, and that those systems really can vary from population to population, even within one country. So it's a really, there are a lot of things for us to consider, and for an LM to understand themselves so that they can help both individuals and organizations and professionals understand as well. And throughout, the focus is on access, understanding, and using. It touches on all those levels as well. It's not specific to the individual, nor just the professionals working at different organizations. We're already at 10 minutes, but I wanted to go ahead and
We're fine with time, Janelle, if you need a little more time. Yeah.
Yeah, so when let me get it to actual size. There we go. When we have been working on this was just the first phase. And in our next phase, we're really looking to go to understand how we're going to apply this framework. So far, we've been really focusing on how an LM can use this framework to increase its own organizational health literacy, and how it can help other organizations increase their health literacy. For example, an LM has been using it to standardize how they incorporate health literacy best practices into their own policies and into the training that they provide. And I think this framework can be really helpful. It's definitely been so within Communicate Health, to really think about and understand the intricacies of health literacy. It's something that I think we all understand on a day-to-day basis, but it's nice to be able to take a step back and kind of recognize that in a systematic way. We're in the middle of phase 2 of this research, so we're just finishing up testing the health literacy framework visual and a companion document that goes along with it. So we'll be refining both the materials based upon the findings from the audience testing we're doing, and then we look forward to creating an interactive version of the framework itself. So I'm wondering what questions, if any, you all have for me.
Thanks, Janelle. Would you mind going back to one of your earlier slides?
Sure.
Sorry.
Which one?
I just was wondering, the earlier one where you talked about what you did to collect the information for the framework.
Yeah. 1 second. Alrighty.
So you looked at the existing health literacy frameworks in the literature, it sounds like. And then I was curious if you also used the 10 attributes of health literate organizations at all in terms of thinking through some of the elements of the framework.
Yes, we did. That was one of the ones that we used to inform this. And obviously, there are a lot of amazing health literacy resources out there and guidance. And for our purposes, we were looking for something that also encompassed really what the individual role and the organizational role was. But that one informed what we put in here as well.
Great, thank you. So just for everyone in the Zoom room, we had 4 speakers this afternoon and all the speakers have now presented. So this is time for open question and discussion. So if anyone has questions for Janelle or any of our prior speakers, please feel free to put it in the chat or raise your hand, your virtual hand. Steve, I guess while we're waiting to see if anyone has any questions, I was curious, what you thought about how Janelle's framework might apply to some of the work you're doing, because you did mention some of the different kinds of organizational or, professional type barriers. So I don't know if you want to comment on that.
Yeah, I think that the establishment of frameworks is a good thing to do. I worry about them being generic enough. I know we all want to drive towards harmonization, and but I think what's difficult about harmonizing things is to get consensus. And so I think there has to be a drive towards, I guess, defining a core set of characteristics that we can all agree on. And I don't know what that looks like going forward, and if it'll have enough, or are we going to be left with stratifying across jurisdictions that have differing values? Like the ethnographic differences are kind of what comes to mind for me.
Yeah, and that's one of the tricky things about this one, and really finding something that works for an NLM, because they are, funded by National Library of Medicine in part, and they literally, their mission is to serve everybody in the United States, whether in an individual or professional capacity, if you work with health information at all. So they did need something that was broader, but also that it acknowledged the fact that there are cultural challenges and cultural differences that need to be accommodated, that need to be recognized, that are very valid. And we don't necessarily, this framework doesn't necessarily have all the answers of how to do that. But one thing that we were really focused on is we're not going to be able to use this, let's say, to address health equity issues if we don't acknowledge those. And that's why one of the key bullets in the visual under social and cultural determinants of health, we kind of expanded that to really put that emphasis on culture and language. To the point of both your presentation as well as Joseph and Vishala, it's like language comes into this quite a bit, and the assumptions that we inadvertently make when we're trying to coordinate efforts with populations who approach life very differently, in part because of what their primary language is.
Yeah, I think that, to your point, I think we really need to engage with not only native speakers, but people who are part of the culture for which we're trying to reach. Because we have a phrase, let's say, I want to live as long as possible. Well, maybe in a different culture that needs to be communicated in some different way that's more meaningful to them, because a literal translation just won't do it.
Yeah.
I also think it's interesting around, this idea of making decisions in healthcare and, part like how culture influences that. If we think about a lot of the health literacy definitions that are out there, and this idea of informed decision making, people, what does it mean to be informed or make an informed decision? two people might get the same exact information, understand it the same way, have a clear concept of what that information is, but still so they're both making an informed decision, but it might be a different decision. And part of that difference could come from cultural values or beliefs. And so I always find that really interesting, right? It's something that I think about a lot. And when I talk about health literacy, often say that, people there's an informed choice, and then there's a choice based on false or incorrect information, and then there's an informed choice, but that choice may not always be the choice that we expect someone's going to make, right?
Yeah, I think that's a good point. I think it's also we have to understand about heterogeneity amongst amongst the group of patients that we consider to be homogeneous. Because everything, like in the cancer space, so I'm a cancer researcher, but in the cancer space, you have to understand that the journey with cancer, it degrades you over time. So you have one treatment, two treatments, the disease progresses, you're getting older, situations at home change, all of these things change over time. And so what was the right decision for you a year ago may not be the same decision you would take today. And I think health systems need to be sensitive to that. And I think, and also your health literacy increases as you experience a disease, a chronic disease, because it has to, in order for you to interact and I think maybe be your own advocate. So, I mean, so I think that I don't think there is a right decision. There's a right decision for each person, but there isn't a right decision that I think we can go across what we consider a specific strata of individuals and say that's you fall into that, so therefore you should act like that.
I also, Steve, was thinking, you mentioned earlier about, thinking about the community is, including community perspectives in work. And I was curious, Joseph and Vishala, I know you had Spanish speakers who coded with the Clear Communication Index, but I'm assuming they were also researchers, correct?
They were trained in public health, or medicine adjacent disciplines. So yes, they were student researchers.
Okay, so I'm curious. I mean, I'm trying to think if I've ever seen this, and I don't think I have, but I'm curious how that might look if you actually had, community members trying to use the Clear Communication Index and rate the information, what their perspectives would be. Do you think that would be different?
Yeah, so the way we thought about this was, well, CCI was created, like how the tool was created and who the tool was created for. But yes, you bring about a very, very good point that, of course, perspective matters. And this is a structured assessment for experts. And in some ways, you are asked to assume the position of your audience. But what if we did something where the audience was asked to rate? Now, I don't think that would be CCI. Again, that's my very 1 minute thought right now. Not very well formed, but yes, it could be very valuable.
Yeah, I mean, if I were to guess, I would think you would get pretty substantial differences, and it's the difference between sort of reading a formal set of guidelines in the CCI instructions and ticking off and saying, okay, yes, this is adequately covered, or no, it's not, versus the perspective of somebody in the community actually trying to use and understand that material. And I could certainly envision many cases where, yeah, right, the box is ticked, but it's still not being maximally useful for the intended audience.
Yeah, we need to assess. Oh, sorry, go ahead.
No, finish what you were saying, Vishala.
No, I was just saying that I think the way to assess that would look differently. It would come from making an assessment of what we missed and what people missed. Or of course there could be an element of you know, how do they feel about the information? Do they, and I think that could then have downstream consequences for like how much they trust it. And I think that has been discussed in the previous sessions today. So, well, how much do they trust something if they don't understand it, or like what? I know there was a big discussion about numbers earlier, but I think some of the same rules apply to text.
It's interesting. So we were working with NLM a few years ago, and they were trying to come up with a pared down tool that people who are not health educators or health communicators could use to help assess, is a health education material that they're sharing easy to understand for somebody with limited health literacy skills. And so we helped them develop, I think it's like 10 items, health education material assessment tool. It was, we started off with the PMAP-P. But what was interesting is when we were going to look at doing a Spanish version of this, it became crystal clear. Obviously, we all have talked about transcreation, right? You can't just translate something. You really need to create it inspired by the original, right? But what does that mean? And who needs to be doing that transcreation? And one of the things we took away was you need somebody who embodies that culture from like they were born into it, that they really experience it in an inescapable way to be part of your team. You can't just bring them in to test it. You can't just consult with them. And that really spoke to the need to really integrate so many varied perspectives into the teams of people who are helping develop communications and other health materials, products for all these varied audiences, most of whom, or many of whom, are underserved. So it's a really tricky situation, but I just love the fact that it really highlighted, you know, bringing more people into the conversation, into the mix.
Thanks, Janelle. And Michael, you have your hand up?
Yeah, so I'm sorry I had to jump in between rooms for a bit, so I'm sorry if I missed, but you know, a lot of this, a lot of the motivation behind some of these checklists and mechanisms to evaluate materials and sites and everything can also bring us away from actually testing with the target population, you know. So and even if it's not going to happen with every single next piece of material, but like, you know, when you're coming into a new mode, or when you're coming into a new team, or coming into a new topic, just, you know, that it's just really easy to miss things when it's just like, you know, super educated people sitting in a room by themselves thinking about these things, even if there's perfect cultural concordance, right? I mean, anyway, so I don't know if this is a topic that you've been talking about as well yet. We just apropos to your project, Vishala and Joseph, we're about to submit a paper about we just took different folks and sent them to different websites and asked them some very specific questions and saw what they could and couldn't do. So even websites that we thought were, you know, better than others, you know, the capacity to answer some very basic questions like, am I eligible for another shot now? And, you know, some of the things that you would imagine all these sites should be able to do that. And it was a disaster. Basically, people could not use the sites.
Yeah, no, I think this is something that we spent a lot of time thinking about. We ran surveys during the pandemic at what we consider were critical times in change of guidance. And yes, no, we completely agree with you. This even even when there's a time pressure, I think there's a big lesson here in beta testing the information with the intended audience to figure out what we are getting wrong. And sometimes, I mean, this is not to blame anybody. Like, I mean, agencies were short-staffed, of course, but as you said, some very critical principles get missed. Yeah.
Yeah, there's a whole kind of movement for like user-centered design and all this kind of stuff. And I've just, everything people say to me, oh, this is intuitive design. It's intuitive if it works for you. If it doesn't work, it wasn't intuitive design, right? I mean, and we only know if we have empirical like influences, you know, actually test with people.
Well, and I think a lot of times people will, you know, people feel like they don't have the money or time or resources to do some of that community engagement or run it by community members, but it can be very basic and you can still get really good information. I mean, we worked on a project this spring creating some videos about the HPV vaccine, and we had in our mind what we thought we would include for information. And we're like, oh, you know, we looked at all these things and did all the research, et cetera. And we're like, okay, this is what we should include. And then we got a group together. This is for rural parents. We got a group together, and it wasn't a large group, but it was some moms from the area that we were working in, and they had the most valuable input. I mean, just this small group and meeting a few times really completely changed the direction of we were going in and the nature of the video content. So, you know, it doesn't have, like I said, doesn't have to be time intensive. I think sometimes we, you know, when we think about community engagement from like kind of the NIH grant funded perspective, there's a lot of things that have to go along with it, and you know, including the community as researchers, and all of that is really important. But sometimes this was not, you know, a big project. It wasn't something that we wrote a specific grant for, and just doing something very basic even was very helpful. So I think it's good to remember that you don't have to go all out all the time, and because I worry that message then causes people to think, well, we don't have the time to do it the right way, so we're not going to do that. I don't know if anyone else has had that experience.
Absolutely. And I think the other thing to keep in mind is, yes, there are certain limitations to online subject pools, right? You're by definition restricting yourself to people who have internet access and some degree of computer literacy, but in the spirit of, right, not letting the perfect be the enemy of the good, that's another resource that you can draw on. And if you have, right, a couple $100 and a day or two, you can recruit, a reasonable set of subjects to do user testing, comprehension testing, that sort of thing. And from a research standpoint, it's an approach that Vishal and I have used a lot for right after the fact evaluation of communication strategies. But my hope is that some of that work, right, will inspire more use of subject pool of online subject pools prospectively, like we were talking about.
Yeah, that's a great point, Joseph. Does anyone else in the room, any of the attendees, have any questions or ideas they want to contribute to the conversation? Feel free to jump in or put something in the chat. I know it's getting later in the day and people start to lose their excitement and energy. Anyone else have any other thoughts? Make sure people feel.
I'm gonna make a few public service announcements just in the middle, just while people are maybe come up with their questions. One is that we do have another session today, so you might need some caffeine if that's how things are rolling for you. As Jennifer mentioned, we have a little bit of time also for people to see posters, and I really do think it'd be great if you would connect with the posters and poster presenters, and especially can have a risk of getting shortchanged in a virtual meeting. And so it'd be great if you could check them out. Some of them have some very nice little videos associated with them. So the presenters are describing their posters, and you can email them and if you like. And then the meeting goes on tomorrow as well. But another thing is, if you hadn't noticed, which is that we have this Journal of Health Literacy Research and Practice. I happen to be the editor, and anyone who's been at the meeting this year can have a waiver for author submission fee. So you can use the password you can for a HARC 2023 on the website, and then you don't have to pay for author fee, which is maybe a nice added bonus for the conference. Maybe back to this topic though, until another about getting users involved, the target population involved. Fantastic mentee of mine, Christine Gunn, was developing a project, decision aid for breast cancer surveillance screening, and went to the providers and said, what information must be in this tool? What's the key information that we have to convey? And she got all the providers in for input, various kinds of stakeholders, and then went to the patients, and they were on completely different planets. Like if we had only listened to the providers and all the different types of providers, we would have not met the mark at all. The providers were talking about things like, false positive tests, false negative tests, all these different issues. It was really complex stuff, and there was a lot of numeracy challenges, and we were working about how could we do that. We went to the patients were like, is it going to hurt? Where do I go? How do I make an appointment? Like it was just like a different planet. It was a different planet, and we have to figure out how to talk to people in ways that they need as well.
The only thing I will say is I think as physicians, sometimes we can forget how fragmented the system is, and how answering some of the questions around accessing and admin issues can get you so much further with getting patient compliance, or whatever we'd like to.
Well, I would go even further, Vishala. In this example, a fair number of the providers didn't know the answers to these questions. Okay, they didn't even know the answers to the questions.
Yeah, you spend so long training in above that. Yeah, no, that makes sense. You often don't know the answers. I mean, I think I've heard stories about like patients want to know how expensive is this, and before the Epic pop-up appeared in some of the hospitals, you had no idea, and that you were sending this patient, and the only reason they were not going to take this medication was because it was just way too expensive, or the pharmacy closed down, as has been happening, and some of these things.
Yeah. So there's a kind of a detail, like in this example for the breast cancer screening decision tool type of an example. There were basically none of the male providers had ever experienced it. So there's a kind of knowledge that you come from actually having the experience. But even still, most of them didn't know how you made an appointment. So it wasn't even on their radar screen, and they couldn't. People tend to talk about things that they feel confident about and that they know about, and that people are coming to them and asking them about. But anyway, so I think these types of things make it very good reminders to be talking to all the different parties, and certainly the patients too. or maybe public, health contexts. A lot of NLM is public health context, so it's not even patients per se, but really just everybody. Caseworkers at the hospital. That's a good another type of example.
I put the link to the posters in the chat, and also to the journal that Michael was talking about, if anyone wants that information. And it's about 10 to 4. I think this session is scheduled to end at 4. Michael, should we break a little early so people can take some time to look at posters, or do we have any other discussion that we want to have?
No, that would be fine. This is a field where it's absolutely clear, like many hands are going to be needed. There's like much
Yes.
work to be done. And, you know, this is step by step, the longest march kind of situation. And it's going to take a lot of hands and a lot of effort. And so keep up the work, and, you know, just find ways to continue to do it. And we'll need a lot of different methods too. So sometimes I think Joseph's point, then, you know, we can't make perfect the enemy of the good or something like that. I think you said earlier, is, you know, we have to make research fit into our lives somehow or another anyway. And it's going to take a lot of hands, and takes a lot of effort to change cultures. And yeah, I think one of the nice things about this field is it's a kind of a critique against the culture of healthcare in general, of saying, okay, how are we going to include people who actually don't have all the privilege of education, power, and social capital, and all that kind of stuff. All right, be well, everybody.
Thank you, Michael, and thanks everyone for attending today, and thank you to the speakers. It was great conversation, and enjoy the rest of the conference and have a great afternoon. Bye, everybody.
Thank you.
Thank you, Jen.
Thank you so much.